Assalamu alaikum everyone. I hope you're all doing well and Ramadan Kareem. So today I'm going to be giving you guys a PAL session on globular protein. So this is part of the HLS block in first year. I'm part of integrative biochemistry. So today, these are the general learning objectives that we're going to look at. So we're going to describe the structure of hemoglobin, understand between its different states, describe something called the oxygen dissociation curve, which is very important for you guys to know. And then we're going to have some clinical correlates towards the end. But first, I have a question for you guys. Why do we breathe? And many of you may answer, because we need oxygen, right? So when you breathe in, you're going to get oxygen from the air, and you're going to breathe out carbon dioxide. But the key thing is, okay, we know that our tissues need oxygen, then we get it from the air, that's why we breathe. But how does this happen? So how do our tissues receive oxygen? Well, first we know we get oxygen through the air, through our lungs, right? By diffusion across the alveoli. And then carbon dioxide is transported out. But a question still remains as to how does this exactly happen? So when we look at our cells, how does our oxygen get from point A, which is in the air, all the way to the exact tissue that needs it? How does this work? Well, the reason this happens is because of a protein called hemoglobin. So hemoglobin, from its name, has two parts, heme and globin, okay? And it acts as the carrier of oxygen in the bloodstream. Okay, so this starts to make sense. So hemoglobin in our red blood cells is going to take that oxygen that diffused from the alveoli into the capillaries, and it's going to hold on to it, and it's going to transport it to my tissues. Okay, so that's the essential concept that we're learning about today. And each of these hemoglobin molecules consists of 4 heme components, okay, surrounding a globin structure. And we're going to look at what that looks like in a second. Okay, so in our red blood cells, you can see that these are our hemes, heme group, heme group, heme group, right, inside of these globin molecules. And the important thing for us to know is that every single one of these heme groups has an iron. If you can notice it here, it's in red. And so this iron is what's going to actually bind our oxygen. And we have these different chains that are formed, this beta chain, this alpha chain, and we're going to look at how the structure works in 1 second. I'm just going to use the pointer. Here we go. Oh, here we go. Laser pointer, that's much better. Okay, so this is exactly what the heme structure looks like. Remember, there are these little things that we see here. So heme is composed of protoporphyrin and ferrous iron. Remember, it's ferrous, which is Fe+2. Okay, and the reason this is important is we can see this protoporphyrin structure and this ferrous iron in the middle. And so this ferrous iron was actually going to bind to our oxygen molecule here. Okay, and so we can see that here it's in the center of our protoporphyrin ring, and then this Fe+2 is what's going to actually bind our oxygen. All right, and this can form 2 additional bonds. So we said it's going to bond with oxygen, okay, and it can also bind with the histidine residue of the globin molecule, which is basically the reason that allows it to sit within the structure here. Okay, so that's basically how heme works. And then other than hemoglobin, which has 4 heme groups, you have something called myoglobin, which has 1 heme group. Okay, so if it has 1 heme group, that means it can only bind 1 oxygen, and it functions as a reservoir for oxygen. So myo means muscle, and globin is referring to our protein chain. So myoglobin, right, is this type of protein that's found in heart and skeletal muscle, this type of heme protein. And so in our muscles, we require oxygen, right, for glycolysis and the process of producing energy. And so it acts as an energy reservoir, or it holds on to these oxygen molecules. Okay, but you can see the difference here, how hemoglobin has our 4 globin chains with our hemes. Here you only have 1 chain, right? So remember, only 1 heme molecule means only 1 oxygen. All right, and that's going to be important for us to look at later when we talk about the oxygen dissociation curve. And so again, just to revise, this is the hemoglobin structure. You have your different chains. You have your alpha chains and your beta chains, 2 of each. And in between one, you're going to have your heme. And this heme is going to have a protoporphyrin ring with an iron atom in the center. This iron is going to bind oxygen, and it can also bind to the histidine residue of this globin chain which is what allows it to basically connect there. Okay, so that's our hemoglobin structure. Now, I just want to have a quick note because I'm going to refer to them later on. So you have different types of hemoglobin. Hemoglobin A, hemoglobin F, and something that we're going to talk about in a second known as hemoglobin A1C. But hemoglobin A is for adult form. So this is the main adult hemoglobin that you and I have in our bodies right now. And hemoglobin adult has lower affinity for oxygen than fetal hemoglobin. So why is this important? What does this mean? Well, affinity is how strongly something binds to something else. So when a mother is pregnant, okay, the baby is not able to breathe, right? The baby is obviously in the womb and it's not exposed to the outside environment and it's not at a stage where it can breathe. So it needs to get oxygen from somewhere else. In this case, it's going to get oxygen from the mother through the placenta. And so by this mechanism, when the fetal hemoglobin binds to this oxygen very strongly, it kind of allows it to take more from the mother in order to support the growth of the baby. So that's why we have hemoglobin F, that's usually in gestation in the fetal stage in order for the baby to compete with oxygen from the mother. However, as you go on through life, you'll notice that you don't need to bind as strongly to oxygen because you're not competing with anyone or anything in normal people. And so by that, we're going to have hemoglobin A, which binds a bit less, which means you can release more oxygen to your tissues. Okay, so that's the different types of hemoglobin. And then you have something called HbA1c. So HbA1c is basically when a glucose binds to this hemoglobin. You can see how here you have these molecules and your NH2s. And when you have a lot of glucose in the blood, it's going to bind instead. And that's what we call the process of glycation, right? Or this is happening without an enzyme. It's just because there's too much glucose present in the blood over a long period of time. So you get your glycated hemoglobin or HbA1c, right? And so when this happens, this is usually because you have excess glucose in the blood over a long period of time. So it depends on the plasma concentration of your glucose. The higher your glucose for a longer period of time, the higher your HbA1c will be. And this is very important clinically because this is actually one of the main things we use to diagnose diabetes. Because in diabetes, you have high blood sugar for a longer period of time into where it's pathological or there's a disease in this case, okay? So these are just the quick notes, different types. But for now, just keep in mind hemoglobin A and hemoglobin F. Okay, and the difference between them in terms of affinity. So now we talked about how you have hemoglobin, and that's how your oxygen is transported to tissues and that it binds, right? But there's a specific process that happens when each oxygen binds to hemoglobin. A conformational change occurs, or there's a change in the shape of the hemoglobin itself. What do I mean by this and why does this happen? Well, if you look here, okay, in this case, you have no oxygen bound to any of the heme groups, right? Heme groups are these little pink things with the purple dot in the center, which represents iron. So when you have no oxygen bound, this is considered the taut form. Think taut like it's very tense or it's very tight. This is the T form of your hemoglobin structure. But what happens is if you bind one oxygen, it starts to loosen up a bit. Makes it easier for the next oxygen to bind, for the next oxygen to bind. It becomes more relaxed. So the more oxygen this hemoglobin molecule takes on, the more it's going to not be as tense, it's going to relax. All right. So remember, our deoxyhemoglobin, or the taut form, the T form, has a low affinity for oxygen. All right. But the relaxed form, when one oxygen starts binding, it makes it easier for the next one. And this is a process called cooperative binding. Okay. So this is basically what happens. So this is the taut state, the T state. Remember, it's very tense, okay? It can't bind, or it can bind, but it's very difficult for it to bind to hemoglobin. When one hemoglobin binds to it, okay, it starts to loosen up. Another one, it starts to loosen up a bit more and more and more, okay? So the more oxygen binds, the easier it becomes for another one to come in, okay? So that's what we call cooperative binding. And this is going to be important in a second because this is the reason we're able to measure the oxygen dissociation curve, or what it looks like, is because of cooperative binding. So now I'm just going to go through what's written in your slides given by Dr. Hana. It's the same concept we just talked about, just in the form of words. Okay, so the hemoglobin tetramer is composed of two identical dimers. alpha 1 beta and or AB1 and AB2. Okay, so basically, tetramer just means you have your 4 hemoglobin chains. Okay, and the 2 dimers are held together primarily by polar bonds. Okay, weak interaction between the dimers allows them to move with respect to one another. And this movement results in 2 dimers occupying 2 different relative positions in deoxyhemoglobin as compared to hemoglobin. So what this is saying is basically this. Remember how we said there's the taut state where you have weak bonds and then it gets more relaxed and relaxed and relaxed. That's basically what we're talking about here. The more oxygen binds, the lesser the bonds between the globin structures are. Right, the weaker oxygen disrupts these hydrogen bonds. So you go from your taut form, which is your deoxyhemoglobin, to your relaxed form, which is your oxyhemoglobin. Okay, so that's basically just what this is mentioning here. And this is the same thing, but in a schematic diagram. So you can see the strong bonds here, and the more oxygens that bind, the weaker these bonds become. Remember, this is the relaxed state. It's fine. Everything is good. We have oxygen, so your hemoglobin is able to relax. The job is done. Okay, again, same concept, just as it is written in your slides in the terms of words. So remember, deoxyhemoglobin, there's no oxygen, it's very tense. Okay, oxyhemoglobin is very relaxed. So these AB dimers interact through a network of ionic bonds and hydrogen bonds that constrain the movement of the polypeptide chains. T conformation, or the tense form, has a low affinity for oxygen. Okay, and it says binding of oxygen causes the rupture of some of the polar bonds, allowing movement, right? So this becomes relaxed. This has a high affinity for oxygen. Okay, again, this is the same thing, just in terms of a picture. So this is the tense form, and then you can see how much more separated the molecules are when it's in the relaxed form. All right, this is again one last final picture to hammer it in. It's the same one we saw initially. And so it just shows you that here you have here you have your bonds, you have many of them. This is the tense form. And then as more oxygen binds, a conformational change happens and you get your relaxed form. Okay, so I hope this is clear now. And so what I want you guys to remember is that the concentration of oxygen in your arteries is more than that in your veins. Okay, and so what that means is the partial pressure of oxygen, or the amount of oxygen, the measure of oxygen in your arteries is higher than that in your veins. So if you have more oxygen in your arteries, okay, would you think that the hemoglobin would exist in the taut state, in the tense, the T state, or in the relaxed state, because you have a lot of oxygen present? Feel free to, of course, like pause the video and answer these questions before I give you the answer. But so the answer is, when you have a lot of oxygen around, remember, if one binds, it's easier for the rest to join in. So it's more likely for it to be in the relaxed state. When you're in your veins, however, when you already gave your oxygen away to your tissues, it's the opposite. It's more likely to be in your tense state. Okay, so in arteries, relax, in veins, tense. Okay. And so why do we talk about this? Remember how I told you, you have your cooperative binding, which is when one oxygen binds, it's easier for the next. Well, this creates a shape that's called a sigmoid shape. It kind of looks like an S. It's not just a straight line up, it has a curve to it. And so this is what we call a sigmoid shaped curve. And so what happens is you can basically see what we were trying to explain. In the beginning, it's very hard for the oxygen to bind. It's difficult. But the more you go, the more there's a rapid increase. This is because of your cooperative binding process. So your oxygen dissociation curve is steepest, or has the greatest slope, when the oxygen concentration is the highest, which would be in the lungs, right? And is lowest the further away you get from the lungs. So in the lungs, you have the most oxygen because that's where you're getting it from, right? You're getting it straight from the source, from the air. So here you'd have a very high concentration, okay? And then as you go down to your tissues, it's going to decrease and decrease, right? So here it's basically like it's giving away your oxygen, away, until you get to your veins, and then it gets all released, okay? And so this is just another schematic diagram. And just by the way, a lot of the screenshots I have and the visuals are from Osmosis. I highly recommend their videos. And I added a link for one towards the end to help you guys if you're still a bit confused with anything. So just to go back to this, it's the same diagram that we just looked at in the previous slide, which shows you the hemoglobin saturation with oxygen over the partial pressure of oxygen. Okay, so as you go up increasingly, you have a higher saturation with this S-shaped or sigmoid curve because of the positive cooperability, okay, or the positive cooperation that we talked about with each consecutive binding of oxygen. So in arterial blood, we mentioned hemoglobin is in the relaxed state. It's fully saturated with oxygen. But in your venous capillaries, it's 75% saturated, remember, because you get more and more into the taut state than the relaxed state because you're releasing your oxygen to your tissues at that point. Okay, and so remember how we talked earlier about myoglobin, how myoglobin only has one heme, so it can only bind one oxygen molecule. Well, for that reason, its hemoglobin curve looks different. There's no cooperative binding because if it just binds to one, it's bound. There's nothing really to it. So we know that for hemoglobin, it's a sigmoid shape, but for myoglobin, it's hyperbolic, or it looks like this. Just goes straight up. There's no S shape. There's no positive cooperability that's showing you a different type of curve. And so if you have disease or you have other conditions that change hemoglobin's oxygen concentration, it can cause it to shift to the right or shift to the left. Okay, so this is just to show you the difference between hemoglobin and myoglobin. But what I want you guys to know as well is this hemoglobin curve can shift one way or the other. I'm just going to zoom in so you can see it. This point here is what we call the P50, okay, or the partial pressure of oxygen at which half of all of these molecules are saturated. So you can see that how for myoglobin, it's super low because it just will automatically bind. But for hemoglobin, it's a bit higher. And what they're trying to describe here is you have specific factors that we're going to talk about that can either shift your curve to the right, meaning you need more oxygen to bind to the same amount of hemoglobin, or to the left, meaning you need less amount of oxygen. And I'm going to give you guys the rules and how to memorize that in a second. But when we say shifting, this is what we mean, right? So this is, again, hemoglobin, myoglobin, and this is going to be our P50. So you can see how hemoglobin is much higher. But you can have specific things that might shift this curve to the right, meaning it's harder for oxygen to bind. You need more oxygen to bind to the same amount, or shift to the left, which means it's easier. Okay, you need less oxygen. All right. So that's the different curves. And so what we call these factors that are going to affect the oxygen dissociation curve is called allosteric effectors. And the main ones are going to be pH and carbon dioxide, which we're going to talk about first, as well as something called 2,3-bisphosphoglycerate. Don't worry, we're going to get there when we get there, and temperature. Okay, so this is what we're talking about, right? You have your right shift and you have your left shift. And so an easy way to remember this just off the bat, I know this might look a bit confusing, just remember the blue is normal and you can shift it to the right and you can shift it to the left. So remember all of these factors that we're going to be looking at. Shifting to the right means you need more. Just remember the R and more is for shifting to the right, meaning higher levels of carbon dioxide, higher body temperature, more H+, which means more acidic or lower pH, and increased levels of 2,3-BPG. This is going to cause your curve to shift to the right. Okay, and the reason this happens, I'm going to say this generally so that you keep this as a principle in your mind. This is because all of these things, when they increase, they're actually going to stabilize the taut state. And remember, when it's taut, it's very tense. It's hard for it to bind. So it makes it harder for the hemoglobin, or the heme technically in hemoglobin, to bind to oxygen, because these things, when they increase, they're stabilizing it in the more taut state. So you need more oxygen. You need higher partial pressure of oxygen to achieve the same effect or to saturate these molecules. So here, so your P50 increases, you need more oxygen to do the same thing. However, if all of these things decrease, the opposite effect happens. If you have lower carbon dioxide, colder body temperature, lower H+, which means more alkaline pH, or decreased 2,3-BPG, this curve is going to shift to the left. So this means you're going to have more molecules in the relaxed state, so it's easier to bind. But just remember this key principle. Remember, right is more and left is less. So this is just going to help you guys differentiate it even before we start. Now, we're going to begin to understand how this happens, what happens exactly. So first, let's talk about carbon dioxide and pH. So we know from what we asked in the beginning, why do we breathe? We breathe in oxygen and breathe out carbon dioxide, right? But carbon dioxide is normally going to be present in our blood anyway, even if we're breathing it out, because we need it. What happens is this carbon dioxide dissolves in blood plasma, okay? And when you have increased partial pressure of carbon dioxide, this gets into the red blood cells. The red blood cells have an enzyme called carbonic anhydrase, which turns it into carbonic acid, and this is usually the state it exists in, bicarbonate ions and hydrogen ions. Now, I don't need you to memorize this equation, but what I want you to understand right now is the more CO2 you have, the more that this is going to be shifting and converting it into H plus, into hydrogen ions. And you know, if you have more hydrogen, that means you have more acid, right? Your pH becomes lower. So there is an important relationship between the level of carbon dioxide and the level of acidity. So the more CO2, the higher the pH. Of course, there's other things that affect it, but I just want you to keep this principle in mind. And why do we care about H plus and CO2? Is because these two things can bind to hemoglobin, okay? So they can bind to hemoglobin in two different ways. This acid that we're creating can bind to the side chains on the globin units, okay? And carbon dioxide specifically can bind to the terminal amino acids inside your globin subunits, if you can see it here. You can see this kind of highlighted in yellow. And this forms something called I have to say it slowly because you know how biochemistry is, carb amino hemoglobin, okay? So you have your carbon dioxide, amino binding to your amino acids, hemoglobin in your hemoglobin, okay? And what these do, both your H plus and your CO2, once they bind to your globin subunits, this stabilizes the taut state. Remember, your taut state is tense. It's sticking together. It's more difficult for your oxygen to bind. And so this decreases hemoglobin's affinity for oxygen. It makes it harder for it to take in an oxygen molecule. And it forces unloading of CO2, all right? So let's stop and think, why would this be important? Let's say you're exercising, okay? You're exercising, that means your muscles can produce more lactic acid. Lactic acid means you have more H plus. And so when the hemoglobin gets to your muscle and sees that it's very acidic, it's going to stabilize the taut state and it's going to force it to release this oxygen. Okay, so that means it's going to make it less likely that in a place where it's acidic, a place where your muscles need more oxygen, it's going to say, hey, hemoglobin, I don't want you to take my oxygen. I really need this right now. That's why this environment is acidic, for example. So this is how physiologically this principle can be useful. Of course, in disease states, this can also happen in a negative way, but in a normal human being, that's why we have these mechanisms in place. That's why this biochemistry that we have to learn works in the way that it does. Okay, and just another thing that you guys know, you might know from the term already, but when we're talking about these allosteric effectors, they don't bind to this iron here. Remember, this iron is what's binding to the oxygen. They're not competing for the same binding sites as oxygen. They're binding in another place on this molecule and affecting its ability to bind oxygen. So it's not competing. It's not a competitive inhibitor like it in enzymes. It's an allosteric effector. Okay. So now I'm going to go through the exact wording on your slides and the exact pictures to make sure you guys understand it. So we talked about pH. When you have higher H plus, meaning pH is low, okay, the release of oxygen from hemoglobin is enhanced, right? Just like what I told you guys in the muscles. If your muscle is exercising, it says, hey, it's saying, hey, I need this oxygen. Don't bind to it. So it stabilizes the taut state and says, okay, I'm going to release my oxygen to you because you need it. Okay, so this results in decreased oxygen affinity of hemoglobin and therefore a right shift in the oxygen dissociation curve, meaning stabilization of the taut or the oxyform. All right, so this is just how it's exemplified here in this figure. Okay, so when you have, this is your normal curve. When you have decreased pH at a lower pH, more oxygen is required to saturate half of the molecules, right? So that's what we understood from the first part. Remember, more to the right. And when we talk about more, there's more H plus. pH is lower. I know it might be a bit confusing, but just remember more H plus, so more acidic. Okay, so here you're shifting to the right and you're enhancing the release of oxygen. Okay, so this change in binding, this change in oxygen binding for pH is called the Bohr effect. And that's the equation that we looked at earlier. Now let's look at carbon dioxide. Remember, we already described this. I already showed this to you guys in the figure. Most of carbon dioxide is produced in metabolism. Okay, and it's transported as bicarbonate ion. We already saw this in the previous slides. Okay, remember it's going to be HCO3 minus, and it's going to give us an H plus. Okay, some of the carbon dioxide is carried as carbamate that is bound to the N-terminal amino group of hemoglobin, forming carb-amino-hemoglobin. Remember, carb coming from our carbon dioxide, amino, because it's binding to the amino group, which is N-terminal end. Remember, amino just refers to your nitrogen, and hemoglobin. So there's carbon dioxide binding to the N-terminal amino group in your hemoglobin. Just from the name alone, you guys can gather this information, which helps with memorization and MCQs also. So what do we understand? We understand that we have carbon dioxide in our body. This carbon dioxide can be transported as bicarbonate. This carbon dioxide can also bind to the amino group in hemoglobin, forming carb-amino-hemoglobin. All right, we have carb-amino-hemoglobin. What does that do? That stabilizes the taut form, resulting in a decreased affinity for oxygen. And remember, taut form means you get a right shift in the oxygen dissociation curve. It's more tense, so it needs way more oxygen to get to the same amount of relaxation, to get to the same P50 than it would normally. Okay, so this is just what we mean. If you have, this is your hemoglobin with the amino group, it can bind to oxygen, forming carb-amino-hemoglobin and releasing H+. So remember, this is a right shift in the oxygen dissociation curve, which is basically going to be similar to this. Okay, remember, this is your carb-amino-hemoglobin. So you guys can notice from everything that we're talking about is when you get something that causes it to turn into the taut form, it's more likely going to cause a shift to the right. Okay, and that's what I tried to explain to you guys in the initial slide when we introduced this concept. Now we go to something called 2,3-bisphosphoglycerate, okay, or also known as 2,3-bisphosphoglyceric acid. You might see it in different ways in different textbooks. But the important thing for you guys to know is that this is a byproduct of glycolysis in our RBCs. Okay, so glycolysis, oh my God, I hate that lecture. I completely get it. Biochem is not the easiest sometimes. But what's important for us to know is in hypoxic conditions, hypo means low, oxic refers to oxygen. So conditions where you have lower oxygen in the blood than normal, you're going to have higher amounts of this 2,3-DPG. Okay, and so what this is going to cause is this is going to, again, same trend, stabilize the T state. And when we have something stabilizing the T state, it's going to decrease hemoglobin's affinity for oxygen and force unloading. Okay, let's take a step back. Let's not think in terms of biochemistry. Let's just think in terms of logic. If my body has low oxygen, I'm in hypoxic conditions. Let's say, for example, I'm at a place where that's very high altitude. I live in the mountains where the amount of oxygen I'm getting is not as much as someone on the ground or on sea level. So what is my body going to do? It's going to say, okay, I have low oxygen. So I need to come up with a way to make sure the low oxygen that I have gets released to my tissues. That's what 2,3-BPG does. It's basically a signal in my body that says, all right, there's low oxygen. My tissues need to get it somehow. So what I'm going to do is I'm going to cause my hemoglobin to stabilize in the taut state, okay, because that's going to make sure that I let go of as much oxygen as possible to the tissues that need it. Make sense? So this happens in people that live in high altitudes, as I mentioned. And this can also be seen in cases where people have chronic hypoxia or low blood levels over a long period of time for other reasons. Like a disease and whatnot, to make sure that the body gets the oxygen that it needs in any way it can. Okay, so this is, again, same concept as it's written in your slides. So this is what your 2,3-BPG does. It binds to the positively charged cavity formed by your beta chains of the oxyhemoglobin. And this is going to basically alter the bonds here and stabilize the taut state, make it basically a bit tighter. All right, so this is going to be increased. So your hypoxemia, like we mentioned, high altitude, is going to increase your synthesis of 2,3-BPG. What does this do? It binds to hemoglobin right here, to a positively charged cavity, and stabilizes the taut state. This decreases hemoglobin's affinity for oxygen and decreases O2 unloading. And remember, anything that stabilizes the T state causes it to shift to the right. Okay, so this is how it's exemplified here. So this is shifted to the left if you have absolutely no 2,3-BPG. Okay, blue is normal. And if you have hypoxemia, so high altitudes over time, synthesis is going to increase and it's going to cause a right shift of the curve. Okay, so you're going to need higher oxygen in order to get the same amount of P50 here. Okay, so again, normal, 2,3-BPG increases. Remember, more is shifting to the right. So higher levels seen in high altitudes, because you get hypoxemia, is going to cause increased synthesis, and that's going to cause your curve to shift to the right, as you can see here. Last but not least, we have temperature. Remember, again, same principle or mnemonic I keep talking about. More means you're shifting to the right. So when you have higher temperature, that's going to affect the strength of the bond between your oxygen and your hemoglobin. Okay, and so when you have higher temperatures, it's going to cause the taut state to be more common or more prominent, and that's going to cause more unloading of your oxygen. All right, and lower temperatures will do the opposite. So just remember, for everything I mentioned, anything that causes it to increase is going to shift it to the right. Anything that causes these factors to decrease is going to shift it to the left, as you can see here. Okay, so we're talking about normal adult hemoglobin, or HbA. So this is our normal curve. How do you shift to the right? Remember, more shifts to the right. So more CO2, more temperature, more 2,3-DPG, and more H+, which is more acidity or lower pH. So these things are going to cause your curve to shift to the right. All of these things decreasing is going to cause your curve to shift to the left. Okay, so lower carbon dioxide, lower temperature, lower 2,3-DPG, and lower amounts of H+, which is higher pH. All right, so this is going to cause your curve to shift to the left. Left is less, right is more. Okay, and last thing is HbF. Remember what I tried to explain to you guys, how in a fetus or in a growing baby, it needs to attach to the oxygen more strongly. So that's going to cause your curve to shift to the left as well. Okay, and remember that these are allosteric effectors. So these are not binding to the same site as oxygen. They're only binding to another site and affecting how the hemoglobin structure looks. Okay, so it's affecting its affinity for oxygen, but not capacity to bind to it. This is, again, the same figure I showed you guys, just to hammer it in. To the right means more, to the left means less. Okay, and when we say more, we mean more H+, so lower pH. And if we mean less H+, so higher pH. Just remember, that's like the one thing that might be tricky, but this is an easy way for you guys to keep all the facts straight. So now, So now let's take a case study, because inshallah, you guys are going to be doctors. So we want to make sure that you understand how to actually apply your knowledge, or what this might look like. Or for me in biochemistry, what I always struggled with is understanding, why is this important? Why am I learning this? Why am I spending hours and hours memorizing these molecules and weird names and whatever? But it actually has a very important clinical correlation that you guys are going to understand. So this case says a 33-year-old woman is brought to the emergency department 30 minutes after being rescued from a fire in her apartment. She reports nausea, headache, and dizziness. Physical examination shows black discoloration of her oral mucosa. Pulse oximetry shows oxygen saturation of 99% on room air. The substance most likely causing symptoms in this patient primarily produces toxicity by which mechanism? Okay, so that might seem like a lot to take in, but there are some key things that I want you to guys keep in mind, that I want you guys to keep in mind that are listed here. So first, she's being rescued from a fire, and fires usually have high levels of carbon monoxide. And so this patient actually has carbon monoxide poisoning. And so you can tell that she has a lot of soot because she has black discoloration of her oral mucosa. So that's from the fire, most likely. And despite this carbon monoxide poisoning, she has a very high oxygen saturation. This is very interesting. We're going to see why in just a moment. So what is carbon monoxide? So carbon monoxide is a colorless, odorless gas that is released from fires. And that's one of the reasons, other than your house burning down, that people say, hey, be careful if you're keeping the stove on, because you can get like higher levels of carbon monoxide over time. So what does it do? Why do we care about it? Well, remember how we talked about the allosteric effectors that don't compete with oxygen binding spots? Carbon dioxide does the exact opposite, okay? Hemoglobin has an affinity that is over 200 times greater to carbon monoxide than oxygen, meaning if you have hemoglobin, you have carbon monoxide in front of it and oxygen in front of it, it's going to sprint towards the carbon monoxide. It wants to bind to it instead of oxygen. Well, obviously, this would pose as a very huge problem in your body because you need that oxygen and it's just going to kind of ignore it and leave it alone, which is not going to be helpful in getting oxygen to your tissues, which is the reason we have this whole lecture and the reason we breathe and the reason we have hemoglobin, right? This is poisoning. This is a toxicity. This is causing a huge problem. And so what happens is your affinity for oxygen increases at sites that are not filled by CO or carbon monoxide. So what happens is basically, let's say you have, we have 4 oxygen molecules that can bind to 1 hemoglobin. So what happens is if your carbon monoxide binds to one site, at the other places, it's also going to bind very strongly to oxygen, meaning that it's going to be very, very difficult for this molecule to let go of the oxygen because carbon monoxide is present, because its affinity is very high. So this carboxyhemoglobin that forms, okay, is going to cause very less amounts of oxygen to be released into your tissues. So carbon monoxide doesn't unload easily. And now your binding spots are also unavailable to oxygen. So a bunch of problems are happening at the same time. Your carbon monoxide is binding to your hemoglobin, okay, which means that the oxygens that are already there are not being released, okay? So that's one problem. Now the oxygens can't bind and can't fix the problem, right? So this plethora of problems becomes created because of carbon monoxide. And that's actually the reason why it's poisonous. You're not getting the oxygen to your body as it should be. And so this, we know, is our normal sigmoid curve that happens because of the cooperability between the different hemoglobin components. As one oxygen binds, it becomes easier for another. But you can see now when you have carbon monoxide, it kind of just flattens off. So you can see here that no matter how much partial pressure you're increasing, it's kind of stable. You're not able to fully saturate your hemoglobin with oxygen, which is obviously going to cause a big problem for us. And so what does this look like when we talk about it in the slides? So carbon monoxide binds tightly, but reversibly to the iron and hemoglobin. Okay, so remember, it's binding at the same site. It's not an allosteric effector. It's binding at the exact same site as our oxygen. Okay, so when carbon monoxide binds to one or more of the 4 heme sites, hemoglobin shifts to the R conformation. Okay, this causes the remaining heme sites to bind to oxygen with high affinity. So it makes more sense. Remember what I told you? When one carbon monoxide molecule binds, which it has very high affinity for, it's going to cause the other oxygen molecules to bind very easily. But it's going to bind so easily and so tightly that it can't be released to the tissues. Okay, so this shifts our oxygen dissociation curve to the left, because remember everything we talked about, anything that stabilizes the taut state shifts it to the right. Anything that stabilizes the R conformation shifts it to the left. Okay, and so this does 2 things. One, it shifts the curve to the left, as you can see here, and it changes the normal sigmoidal shape because cooperative binding is not working anymore. So it changes it to a hyperbolic shape, which you can see here. So what they mean by 50% is if half of your hemoglobin have one carbon monoxide molecule, this is the only amount of oxygen that you're going to be able to get. Okay, so this is affecting the ability of you to release your oxygen to the tissues. So that's our first case, and I hope you guys have some clarity on what carbon monoxide poisoning is. And if you need any more information, it's also listed in the note section of the slides, okay? So now let's take another case. So you have a 4-year-old boy who recently immigrated from Ghana, is brought to the physician because of a 5-day history of pain and swelling in his hands. He had similar episodes in the past. The patient appears distressed. His temperature is 38.1 degrees Celsius, which means he has a fever. Physical examination shows pallor. Pallor is important. We'll talk about why in a second. The dorsum of his hands and fingers are swollen, warm, and tender to palpation, meaning they're very big and puffy, and it hurts when you touch it. Okay. His hemoglobin concentration is 8.4. The leukocyte count is 16,000. This basically means he has low red blood cells, meaning he's anemic, and high white blood cells. Peripheral blood smear shows sickled red blood cells. What disease does this patient have? Well, let's look at all these features together. So patient is presenting with what we call dactylitis, which is inflammation in the fingers, okay? And he has pallor, meaning he's anemic, and this is confirmed by his low hemoglobin concentration of 8.1, okay? And this peripheral smear shows sickled red blood cells, which is disease called sickle cell anemia. So that's what this patient has in this case. And so sickle cell anemia is something that we categorize into a big group of disorders called hemoglobinopathies. So from its name, hemoglobinopathies. Hemoglobin, okay, so there's a pathology with hemoglobin. There's a problem going on here. So it can be due to many different reasons. Either you have a production of an abnormal hemoglobin for one reason or another, okay, or you have decreased amounts of hemoglobin. You're not producing enough. Okay, so one of the reasons that can happen, and the reason this happens in sickle cell anemia, is in your 6th position, your glutamic acid is changed to valine. So this completely shifts the way that this hemoglobin molecule is going to fold, and that leads to a process called sickling. You can see how it looks like a sickle, which is basically, I can show you guys a picture of a sickle later, but that's why they call it that, because it has that shape. You also have something called hemoglobin C disease, or HBC, and thalassemias, okay? Okay, so sickle cell anemia or sickle cell disease is an autosomal recessive condition, okay, characterized by replacement of your glutamic acid by valine in the 6th position. And what happens is our normal structure of hemoglobin is not there anymore. It's misshapen. The beta globin chain has a problem. And what happens in brief is your red blood cells sickles when deoxygenated. So when it's under stress for any specific reason, this is going to cause it to basically like almost shrivel up, have an abnormal shape because of this abnormal beta globin amount. So this can lead to many things. First of all, premature destruction. Your body is going to see that you have these weird red blood cells floating around, so it's going to attack them, all right, or cause them to be sequestrated in the spleen. Okay, and when that happens, you can get things like splenic fibrosis, where you get your spleen has multiple infarcts, or you have hypoxic episodes in the spleen over time that causes fibrosis and necrosis eventually, or death of the spleen, okay, which can shorten the patient's lifespan due to infections. And what we actually saw in the case is a result of vasoocclusion. So we know that our normal red blood cells are biconvex disc. Or is it biconcave? You tell me, okay? Because you guys should know this in HLS, the most basic thing. So that aside, what that's going to do is these cells, when they're sickle-shaped, they're not going to be able to properly flow through your blood vessels, especially your very tiny, tiny capillaries, like the ones at the very tips of your fingers. So what happens is that these sickled red blood cells get stuck in these tiny capillaries. And when they get stuck, that's going to cause a lot of swelling, a lot of inflammation, and that's going to lead to the presenting symptom that the patient had, which is dactylitis. Okay, so that's one of the clinical features of sickle cell disease. I'm sure you're going to learn more about that in your specific HLS modules, but I just want you guys to understand why this is happening. So let's look through your slides. So sickle cell anemia is a genetic disorder of the blood caused by a single nucleotide substitution, a point mutation in the gene for beta globin, right? So we said glutamate at the 6th position has been replaced with valine. So what that does is it causes 2 mutant beta globin chains, okay? And under conditions of stress, deoxygenated hemoglobin S is basically going to condense together, and that's going to cause our sickle shape. Okay, and what happens is during electrophoresis, which is basically when we're almost filtering the proteins by allowing it to be attracted to a specific point, which is usually the anode. Okay, what happens is HbS is going to migrate much more slowly than our normal HbA. And this is important because we're going to be able to detect this clinically. All right. And you have another disease that we talked about called HBC disease. So this is another conformation of hemoglobin, and it's going to be even slower than HbS. So you can see them as different bands in your hemoglobin electrophoresis. And clinically, this looks like this. And this is an actual test we use to diagnose these patients. So here in sickle cell disease, all right, you have different components. I'll explain on here first because it's going to be easier for you guys to see. Okay, so you have your gel that you put, which is here, okay? And then you have different points in the gel that you load with your sample. And then you're gonna run an electric source, a power source. And you have your anode, which is the positive end. And so your proteins are negatively charged, okay? And so this negative charge is gonna be attracted to the positive charge. So it's gonna run through the gel, which is why you see these different features, okay? So here it's going to go towards, but remember HbS is much slower, so it's going to appear as a band on a different point. Okay, and HbC is even slower. Okay, so it's going to go, it's going to be more towards the base of the gel or the origin. And so this is what it's going to look like. In your normal adult, you're going to have high amounts of HbA, which is modeled here. Okay, and some of HbA2, which you might see in some of your lectures. In a newborn, remember, you're going to have high levels of HbF because they need to compete with that water from the mother, okay? That oxygen. In sickle cell disease, you're going to have high levels of HbS, okay, or your sickled hemoglobin. And then you have something called sickle cell trait, which is half-half. So it's a heterozygous mutation where you get some HbS, some HbA. And then you have your C disease where you're going to have higher levels of hemoglobin C, which you would see here earlier in that point. Okay, so this is just so you guys understand what the concept is. So this is the pathogenesis. So remember what I told you guys, if you have any stressful situation, then you get your symptoms of sickle cell. So why does that happen? Well, oxygenated hemoglobin is soluble, usually has no problem. Okay. However, deoxygenated HbS polymerizes into insoluble aggregates. Okay, you can see how here this defective hemoglobin is sticking together. It's polymerizing. Okay, and so when you have the oxygenated states, when the body is under stress, such as infection, hypoxemia, maybe they go to a place with high altitude. So anything that puts stress on the body is going to cause this deoxygenated form of HbS to be present, and it's going to more likely sickle. Okay, and what happens? The small microvasculature, like I explained to you guys, becomes clogged with rigid RBCs. You can see how here this blood flow is impaired. Usually, like with your normal red blood cells, it's able to flow smoothly and easily, but here it's going to obstruct the flow. So this can lead to hypoxemia or hypoxia specifically in different organs, and that can lead to infarctions of different organs, and we call this sickle cell crisis. All right, so that's the important thing that you guys need to know. Okay, and what happens is the extent of sickling, okay, so how much sickling is present is going to increase when you have more cells in the taut state. Remember, let's think back to what we were learning about today. the taut state is our deoxyhemoglobin, right? So anything that increases deoxyhemoglobin is going to cause more HBS to be present. So now remember what we mentioned before. Anything that stabilizes the taut form means shift to the right. I know right means more. So what does that mean? That means we have increased H plus or lower pH, increased CO2, increased 2,3-BPG, increased, what was the last one? Increased temperatures, right? So anything that shifts my curve to the right is, in a sickle cell patient, more likely to cause these sickle crises, okay? And that's what's important for you guys to know. Okay, I hope that makes sense. So first thing, we understand that this happens due to a single amino acid substitution in the 6th position. All right, glutamate changes to valine. Okay, and then this leads to the HBS being present. And in stressful states, in deoxyhemoglobin, when you have the taut state, that's going to cause this to distort the shape. It's going to have an abnormal shape leading to sickling of your RBCs. When that happens, that's going to occlude specific parts of your capillaries, the very tiny blood vessels, and that's going to produce your severe pain. Okay. And so to wrap it all up, what do we know? We know hemoglobin is the carrier of oxygen in the blood. We know oxygen binds to hemoglobin by cooperative binding. That creates our sigmoid shape. Okay, and we know in the sigmoid curve, more shifts your curve to the right, less shifts it to the left. So more H plus, it's going to shift it to the right, which means lower pH. Okay, more CO2, more temperature or higher temperatures, and more 2,3-BPG. So that's shifting to the right, taut state. Shifting to the left, okay, is going to be decrease in all of those things, low CO2, higher pH, which means low H plus. And other than those two things, lower temperatures, all right, and lower levels of 2,3-BPG. Also, hemoglobin F. And remember the pathology that we talked about? The pathology that we talked about was carbon monoxide. That's also going to stabilize the relaxed state, which means your body cannot release oxygen to the tissues. We also, in brief, talked about sickle cell anemia and how that happens and how your stabilization of your taut state is going to lead to your sickle cell crises. Okay, and so I hope everything was clear for you guys. I have just like one quick MCQ. If you have any questions, make sure to leave them in the comments of the video and feel free to email me. So this is the question for now, and please feel free to pause the video and read it and rationalize it yourself. So which of the following statements describes the oxygen binding curve of hemoglobin? A, each of the 4 oxygens binds with equal affinity. B, the binding of the first oxygen molecule enhances the binding of the other 3 oxygen molecules. C, the binding of the first oxygen molecules makes the binding of the other 3 oxygen molecules more difficult. D, the binding of the first oxygen molecule has no effect on the binding of the remaining 3. Or E, each successive oxygen bound makes the remaining sites less likely to bind to oxygen. Okay, so that was a mouthful. So now the answer here, which is what we're looking at, is we're trying to find out which of these describes cooperative binding, which, as we know, a principle that happens with hemoglobin. What does cooperative binding mean? It means, okay, if I have my 4 sites of hemoglobin, if I get 1 oxygen, it makes it easier for the next one to bind, easier for the next one, and so forth. So moving from the tense or taut part all the way to the very relaxed state. And so of these, the one that describes it correctly is B. The binding of the first oxygen molecules enhances or makes it easier for the other 3 to bind. Okay, so I hope that concept is clear for you guys. Again, remember, more is to the right, less is to the left, because they can ask you guys different questions about this. They can give you, for example, a case where the patient's pH is low, or they say, oh, they have very high levels of carbon dioxide. What effect do you think this would have on the oxygen dissociation curve? Shifting to the right, which means decreasing affinity for oxygen or increasing unloading, and vice versa. They can give you a case similar to the one I gave you guys with carbon monoxide poisoning. Someone's in a fire and ask, how do you think that's going to affect it? You can, one of the answers may be it's going to stabilize the relaxed state. It's going to decrease the unloading of oxygen, etc. So those are the main concepts that you guys need to make sure to understand through this PAL session. Again, if you have any questions, feel free to email me. I hope this was helpful. And Allah yawafiqkum ya Rab. I hope your MOL exam goes well and your HLS exam goes well and the rest of all of your first year. وعقبال ما نشوفكم إن شاء الله أحسن الدكاترة بالمستقبل. Thank you guys and have a wonderful night. Okay.